IBM Watson Health Executive Webinar Series. Today's presentation is entitled Welcome to the Cognitive Era, presented by Dr. Shiva Kumar, Vice President and Chief Strategy Officer at IBM Watson Health. Before we begin, I would like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation. If your question was not answered, we will respond to you individually after the event. Finally, all registrants will receive a copy of the presentation and link to the recording within 2 business days after today's webinar. The information will be sent to you via the email you registered with. At this time, I will turn it over to our host, Karen Handmaker, VP of Population Health Strategies at IBM Watson Health. Karen, take it away.
Thank you, Sean. We're delighted to have Shiva Kumar here to speak about cognitive analytics and the cognitive era. As Sean said, he is the Vice President and Chief Strategy Officer for IBM's Watson Health Division. His work focuses on developing and implementing strategies and business designs for IBM in healthcare and life sciences. Before joining IBM at the beginning of 2003, Mr. Kumar was an associate principal in McKinsey & Company's Stamford office, where he has worked in the areas of business building related to technology and the use of analytics to improve business performance. And Mr. Kumar is also a physicist, and he taught at Yale as an associate professor. His degree, his PhD, is indeed in physics. We are delighted to have Shiva here, and Shiva, we're ready for you to start.
Thank you very much, Karen, and thanks all of you for joining today. This is an exciting time. There are many changes happening in the world around us, particularly in the realm of health and life sciences, healthcare, and I'm here to share with you some of the work that IBM and others have been doing in cognitive computing. Let me start by explaining to you what cognitive computing is, because this term gets kicked around. Some people understand what it means. The way IBM thinks about cognitive computing is, one, these are systems that learn at scale. Okay, this means they're able to chunk through large volumes of data and knowledge and derive insights. And going beyond that, these systems are able to reason with you. We say reason with purpose and interact with humans naturally is the way the company's described it. What this means is we use natural language, the computer does. It can interact with human beings in the language they use. It understands the specific context of words and can engage in a dialogue with human beings. So this is an important attribute of a cognitive system. A third aspect of this system is it can deal with ambiguity. Namely, the answers are not always definitive. They can be probabilistic. And what that means is if you have a question like, what's the best restaurant in New York? You're not going to get one answer. As human beings, each of us have our own points of view. What the computer would likely do is scour all the knowledge it can access and come back with a knowledge-based view that says, based on the opinions of thousands or hundreds of thousands of people, these are the top 5 restaurants, and it will then give you some added information as to why the answer is what it is. So what I just described is hypothesis generation. Namely, it will say, if these are the criteria against which you're evaluating a particular situation, then this is the most likely answer. And here's why. And this is what differentiates these systems from what's been in existence in the past. The system also has to be adaptive. Namely, it learns as it goes. It learns as the underlying data change. It is interactive. Namely, the way we build the systems, you will engage the system and it will then, in essence, converse with you and help you arrive at an answer. And then it is both iterative, Namely, it learns, it remembers, it can build on knowledge already accumulated, and it's contextual. So what does all this mean? I give you a simple example. If you say my temperature is 102 degrees, is that good? Now, if you were to deal with a system 30 or 40 years ago, it would know that 98.6 Fahrenheit is the right temperature for a human body to be, and 102 is clearly not a good place to be. But a cognitive system would try to go beyond and understand the context. Where is this temperature being measured? Did you just drink a hot coffee? Or is it that you had a fever that was 104 yesterday and is 102 today? In that last example, it's actually a good thing that your temperature is 102 because you were at 104 yesterday and that was horrible. So this is what starts distinguishing a cognitive system from the systems of a few decades ago. From a technology standpoint, it's a set of tools that leverages techniques from data mining, machine learning, deep learning, which includes things like feature learning and feature extraction. And if somebody wants to know more about those things, I can say more. And then artificial intelligence. And the technology is applied across different modalities, namely text, voice, images, numbers, and so on. These are all things human beings do in a natural way without questioning it. It takes a lot of work to get computers to learn how to do this. And what makes today an unprecedented time is technology is finally at a state where it is good enough and fast enough for computers to do the kinds of things that I just described. So I'm going to the next slide here, where what I portray is how technology has evolved since the early 1900s, where IBM was in the business of creating tabulating systems. This is to do something that's very popular these days, which is counting votes in elections. These were done initially using mechanical devices and then electromechanical devices. That's what got IBM going. And in the 60s and beyond, we started getting into the realm of programmable systems, which many of you have used. These are the mainframes, the mini computers. These are now the laptops and desktops that are all around, and now, in some ways, they're already becoming part of history. And while they will be around, most of you deal with mobile devices these days, which have many of the same attributes of these computing systems, except now you can carry them around in your pocket. They do things on the device itself, or they're connected to the internet and connected to large systems of computing. This is cloud computing, and you're accessing a wealth of information and knowledge from these systems. Then I talked about cognitive systems. These are now taking the ability to handle large volumes of data, both structured data and unstructured, and I mentioned text, voice, images, numbers, and we now have capabilities that allow us to make sense out of all of this data and derive insights. What's there in the future for the evolution of these systems is most of these systems today use what are called von Neumann architectures. These are the ways in which the circuits have been built. These are very different from how the brain operates, and what most people in the field know, that a large computer that occupies the size of an office room and consumes kilowatts of power, if not more, in many ways is not able to match what a small object like the brain inside of a head does. It probably consumes about 10 or 15 watts of power and weighs around 10 or 15 pounds. So we, as human beings, we have a long ways to go before computers can do what the brain does. And there's a lot of research going on in IBM to create the systems of the future that operate more like the brain. So that's the system side of it, what is also happening on the data side is the volume of information is proliferating at a tremendous rate. So today, there are about 10 to the power of 15 exabytes. An exabyte is 10 to the power of 18 bytes of information, and that information is doubling every 2 years. A large part of it is unstructured information. This is texts, video, images, and so on. What's also happening is the medical literature is proliferating very rapidly. There are 700,000 new scientific articles each year. And if you're a physician trying to keep up with the latest in science and with best practices, it has become an impossible task. And many of you know it takes 10 to 15 years, sometimes longer, for practices which are known to work and to have proven outcomes to become part of everyday use in the medical profession. So those are some of the challenges being faced, and what we've been working on are technologies that then allow us to assimilate the medical literature, guidelines, institutional knowledge that exists in the best ways to treat patients. You combine that with other information, which becomes very important. And most of you know that most individuals spend perhaps 10 minutes every 3 months or 6 months with their primary care physicians. Some of you who are less fortunate have to see specialists in emergency rooms and so on. Most of your life is spent outside of that setting. And when we use the term exogenous data, this is information about your activity, your mood, your nutrition, and these are all very important determinants of health. And such information, when combined with genomic data, which will become more freely available going forward, and the clinical data that comes from your hospital visits, the combination of all of the data and all of the knowledge, which can then be processed through cognitive systems, then provides the promise of the future, where we will be able to use all of the world's knowledge, specific knowledge about you, to then bring to a point of decision. This could be your meeting with a caregiver, your meeting with a nutritionist, the relevant information that allows you together to make the best decision. And that's really the mission of our team, our organization, of IBM in the health space. What I'm going to do next is give you a glimpse of what happens when you bring all of what I have been talking about together into a real setting. So the cognitive systems that we're developing are able to do a few things. Let me start on the left side of the circle that's on the right side of the page. We have systems that can understand natural language. They have ingested medical texts, all of the guidelines, peer-reviewed articles, your clinical records, and that information is then analyzed and evaluated in order to come up with the best diagnosis and treatment recommendations. So that's what, as you go up on the chart, we say generates and evaluates. It is then looking at all of the information, scoring the information, and coming up with a probabilistic view to say, look, if these are the symptoms, these are the likely diseases that could be creating these symptoms. And then the Watson system will ask you questions to say, have you done this test? If you're a diabetic, I don't see an A1C test result that was done, measured in the last 6 months. Perhaps you should do that test again. And if you do that, then the conversation can proceed. Now, if the disease is much more complex, as is the case in many cancers that Watson is working in, it will then suggest other things that you should look for, which are added piece of evidence that, through a dialogue, enables Watson to come up with a better recommendation or decision. So this is where the learning and adapting comes in, where with more and more information, the system can come up with better information, better recommendations for diagnoses and treatments. And then all of this is done within your context, okay? Because if medications have to be taken, then the system will know that you're already taking certain medications that perhaps won't go with the ones that are being added to the portfolio of medications. There may be other conditions that you have that may be secondary or tertiary conditions, but definitely need to be taken into account. A very common issue is as people grow older, their systems aren't as robust. So as you start treating one aspect of the body and start doing things that might jolt the whole body, you might then have to worry about other systems that might start failing. So you have to take a holistic view of the patient and make sure that both the diagnosis and the treatment, including information about costs of treatment, are then appropriate for the situation. So I'm going to spend a few minutes after this getting into more details of certain examples. And before I do that, on the next page, I want to show you how a combination of what computers do and what humans do can be incredibly powerful. Now at the bottom of the page, I'll connect with comments I've made before. I told you that cognitive systems understand natural language. They can scar the data and recognize patterns. So these systems have access to a tremendous volume of data that goes well beyond what any individual can do in any reasonable amount of time. And these systems have been trained and tuned to learn from the data and come up with information that they can then bring to bear given a context. Now, they're not biased. What is a common problem in the medical field is that physicians often are biased by the last 2 or 3 patients they've seen, and sometimes the way the diagnosis proceeds can be impacted by what's been seen before, particularly if you're in a specialist setting. You're at risk for going down the wrong path, and this is documented as a fairly common problem in the cancer settings, that a significant percentage of the people, the first-line treatment that they go through is not correct. And so elimination of bias is important. And of course, computers never get tired. So they can work all day, all night, and they can give you answers very, very quickly. Human beings can get tired. And so people have to work a finite number of hours when they're productive. Otherwise, we can have errors. Now, human beings do other things that computers aren't good at doing. There's a common sense. You know, if somebody is not going to live very long, they're very old, they're frail, we shouldn't be recommending surgery. Okay, so these are the kinds of decisions that caregivers make on a daily basis to ensure that we're doing what is best for the patient. There are dilemmas. You have situations when you've got to make tough calls. Do I go down this path of recommending this surgery, recognizing that this patient may not survive? What do I do? And so sometimes you have to bring to bear other data that a computer system may not have easy access to. Then we talk about morals. What's the right thing to do? Compassion, making sure we're taking into account the feelings of not only the patient, but the people around the patient. And there's things like imagination, dreaming, abstraction, so on. These are all wonderful human attributes that I hope all of you on this call enjoy, because that's what sets us apart. And that, when combined with our brilliance in the field, when we're able to help other human beings get better and save lives, we can get help from computers to do this better. And that's the promise of cognitive computing. So when you start thinking about how we apply cognitive computing in the health context, there are a few examples that I will pick up from. So in discovery solutions, this is now, imagine you're a life sciences company. You're trying to figure out what the next drug is that you're going to develop to cure a disease that you've been working on. There's large volumes of literature, papers that are written by academics, and it's very difficult for a human being to read through all of these papers and make sense of them. So what we have are a set of tools that can help a researcher engage with all of the literature that exists that's embodied in these cognitive systems and start asking questions about the latest research that may have been done on a particular gene mutation and how that might then connect to the types of medications that might have indications that could be connected with that mutation and so on. So you can go through a dialogue where the whole process is scouring through literature, coming up with candidates and new molecular entities for the next round of testing, gets speeded up significantly. And many of you know it takes many, many years and billions of dollars to get a drug to market. So there's a class of applications where we're hoping to accelerate that process by many years. And that will help pharma companies to lower the costs of bringing drugs to the market. And we can get to much more personalized medicine because, as many of you know, many drugs don't work for most people. They're proven to work in some instances, and they do fabulous things in those instances. There are many other situations where they don't help as much. So that's the purpose of the focus on discovery solutions. When we get into real-world evidence, there are large bodies of data on individuals well past the stage of clinical trials when drugs have gone into the market. So you'd like to find out if there are any adverse effects. And in particular, are those adverse effects related to specific subsegments of the population? Or are these broad issues? If it's a broad issue, you pull the drug off the market. If it turns out that a particular drug is not good for patients, let's say, who have poor heart health and maybe on some other medications, then those are the kinds of things you'd like to find out, so you can give better guidance of who to prescribe a particular drug to, and very importantly, what to expect in terms of the efficacy of the drug to improve the situation of the patient. A related piece of information that pharma companies would like to know is how effective is their drug at what price relative to somebody else's drug in the market. So these are all examples of real-world evidence. And where cognitive computing comes in is we're able to analyze or sift through large volumes of data, which in prior years was mostly utilization data or claims data, but with new technologies you can go deeper and understand clinical data because the cognitive technologies can read unstructured text and make sense of them and combine that with knowledge of utilization and knowledge of what conditions a patient might have based just on their claims data. So that's real-world evidence. In population health management, a big problem facing countries across the globe is finding the right balance between actions that were taken, for example, in the turn of the last century. This whole notion of inoculating individuals against infectious diseases, you had to bring the cost of treatments down to a low enough level that it was affordable to give everybody one of these inoculations, vaccines. As the world has improved on the health dimension and people are living longer, the types of diseases we have to deal with much more commonly are the chronic diseases, because that's where the bulk of the expense in the health system is. So what we have to help through technologies, the cognitive technologies, is to understand the populations better and figure out how best to engage them well before they get into diseased states. So this continuum of wellness through illness and understanding populations and individuals and being able to risk stratify and figure out what actions are the most appropriate. So when a low-cost action is taken against a very large number of people and it can then prevent higher-cost actions in the future, that's what the world needs. And so to do this, you're not relying only on clinical data. You'd like to understand genomics. You'd like to understand the environment in which people live in. You'd like to understand their exercise habits, their sleep habits, depression, what they eat, how they engage in society, and so on. So all of these factors have to get understood. So if you ask, where is population health management going into the future, it is this continuum of illness through wellness. I'm saying that in that order because we focus more on the ill these days than we focus on the well. So we'd like to have fewer people who are ill. And in order to do that, you need information on people, and you need systems that can analyze the information and do two things that are very important. One is engage the individual. So you encourage best health practices. And the second is you engage the caregivers in a manner that optimizes for the utilization of expertise relative to the cost of accessing that expertise. And what I mean by that is, in today's systems, if left uncontrolled, everyone will want to go see the most expert individual, irrespective of what it costs, if they don't have to bear the bills themselves. On the other hand, if each individual takes that kind of an approach, society at large suffers. So we then have to create technologies and capabilities that enable us to engage individuals a lot sooner through education and then through these very powerful mobile technologies that exist that enable us to engage large populations. So we're going from public health to population health management as the next frontier in keeping the world healthy and managing the overall costs of doing so. Then I talk briefly about imaging. So in imaging, those of you who are familiar with what a radiologist's office looks like and what they do through the course of the day, they're scanning through hundreds of images trying to find minuscule variations to then see if they can detect the early onset of some kind of medical problem. And what we're able to do with cognitive computing is start to automate that process where we are teaching these systems to see, to read images, and to then come up with annotations of the images to then highlight areas that are more likely to yield something if looked into further. So a combination of image information, clinical information brought into the right context with the right computer-aided prioritization is going to make the health system much more effective. A related thought I want to share with you, the way a radiologist prioritizes reading images today is kind of first in, first out. I've got so many folders to go through, that's what I'm going to do. A computer system can pre-read all of the images and say, look, these are the patients you should look at first because they're the most critical ones. Then it will also tell you these are the images. Out of the hundreds of images you have, these are the ones that are the most interesting images. And go look at those first. And then you can go look at the others. This is going to result in tremendous productivity improvements, reductions in error, and perhaps a better balance between the amount of imaging that occurs today and making sure that it occurs when it's needed and not because an imaging facility needs to get utilized. So there are very important developments coming in this dimension. So I think the cognitive systems being able to read images and help radiologists and other folks who look at images is going to be very important. I touched on the health and wellness part when I talked about population health. I think the big push here, and we're starting to work with companies like Under Armour, we've talked about, to start understanding better how you can engage patients around good health behaviors, and also through mobile technologies, provide them with the appropriate alerts to encourage good behaviors, which are also going to help manage chronic diseases and some other acute conditions. I call out oncology separately here because cancer is a very complicated disease. There are many, many types of cancers, and while much has been learned, a lot more remains to be learned. And the cognitive systems have been incredibly helpful in helping physicians scour through the large bodies of research that exist to then help patients with coming up with the right diagnosis and then the right treatment. And as many of you know, this is not an easy disease to treat. We do call it a chronic disease today because people can live with cancer. But that said, you have to watch it, keep it under control, and in many instances, the first set of treatments don't work out. So the kinds of systems we're building will enable the system to learn about the patient and aid the physician in understanding why something may not have worked and how you then go to a second line or third line treatment to help the patient recover. And then there are also, as you know, different modalities. You can have surgery, you can have chemotherapy, there can be radiation, medications of various sorts. And as many will point out, many cancers are avoidable just through good diet and exercise. So a learning system like a Watson system can help people and help the patient as well as the provider in a multitude of ways. So that's a broad brush through a broad set of ways in which cognitive computing is being used. I should probably go quickly through some of these other pages and then allow you time for questions. What I have on this page is a little more detail on what we call the Discovery Advisor. I talked about this briefly. I'm just giving you a little more detail here in terms of the types of data that get ingested. So if you're a pharma company, you have these in vitro tests, in vivo studies, you know about compounds, you know about the toxicology of compounds, there's some trial data, there's lab notes, all these things can get ingested and combined with the externally available information on what chemicals are out there, what's known from the genomics perspective, there's textbooks, other sources of information. All of this gets combined together and analyzed in order to come up with the recommendations and hypotheses that researchers can then pursue further to then come up with the next blockbuster drug. Then we have, in the space of care coordination, again, getting more specific, I talked about the early identification and prediction of the evolution of an individual. You can tailor the treatment plans. You can then facilitate care-based intervention where appropriate. And here, some social technologies and behavioral research can get applied, again, through the cognitive computing to better understand a person's mental state, for example, the predilection to be adherent to taking drugs, whether or not they'll follow through, and if they're told exercise this much or sleep that much, do they follow through and do that? If they don't, how can you then intervene? So all of this information can get gathered, sense made of it, and then alerts or interventions sent to points where decisions can be changed and improved to then help manage the health of an individual. And the same technology can get extended to manage the health of populations. What I show on this page is, again, computer-aided analysis for early prediction of congestive heart failure. So the system has analyzed the health progression of different patients, and if a new patient comes in, you can then compare them clinically against other patients. And what's shown in the figure are different pathways that patients could follow based on different types of treatment and intervention. And the reds, greens, yellows are representations of what the system has learned, saying if you take the following path for a type of patient who, let's say, happened to be in the lowest block on the left, and then was given one set of treatments, improved to the one level up in the next column, some treatments beyond that will take you down a red path. That is not good. And then there are, if you go down a green path, it's good. And you do analysis of this type using cognitive technology to help a physician then figure out where a patient is in their journey along a disease progression path and what treatments have worked for other patients who are clinically similar and what might therefore be the best practice, not broadly across the whole population. Those of you who work with guidelines will appreciate that there is literature out there that tells you what to do, but now we're starting to say, how can you tailor that down to the individual, where you're using clinical comparisons of this individual with others whose progression you've studied, and how you can then make the best recommendations for implementing a treatment and following through on adherence. So I've given you a glimpse of different types of applications. I'm going to skip the next page. It is a different application where we're helping in the diagnosis of a patient, but I think I've given you a good enough sense of what we're up to. So what we have today and what I've shared with you is cognitive computing is going to transform the way the health industry functions. And this is not a question of will it transform or an if. It is a question of how quickly these technologies are going to mature to change the way we interact with the health system. Very simply, it is going to lead to better diagnosis, better treatment, and this will get tailored down to the individual, better research and discovery, and very, very important is better engagement of the patient and the physician. So watch the space. There's lots happening, lots of excitement. I'm happy to answer questions at this point and happy to connect with folks later to discuss these topics further.
Thank you, Shiva. That was very enlightening. And please enter your questions in the question section of the sidebar for the control panel. In the meantime, we have a couple questions already, Shiva. Can you help explain whether Netflix and Amazon use cognitive or something else to make recommendations to a consumer? Help us understand the difference if they're not using cognitive techniques.
Well, there's a whole hierarchy of technologies that embody what's called cognitive computing. And so think of this as different levels of sophistication. So without having looked at the code Netflix uses or Amazon uses, as a user, what you experience is that the system understands, let's say Netflix, that you saw a particular movie or you like movies of a certain type. You can then categorize movies into different genres, this comedy or action or drama. Then you can start understanding, okay, does this person like certain actors or actresses or certain time periods? And those kinds of information are then applied to then figure out and make recommendations. Now you can do this with just a keyword annotation of every movie to say this movie is a comedy, 60s, here's the actor, blah, blah, blah. And you can have structured data that do that. You can also have unstructured information where different people might offer comments about various movies, why they liked it or why they didn't like it. There may be reviewers. So to the degree that a system is using more than just the knowledge about the classification of the movies and the ones you watched, it starts becoming cognitive. So the next generation of such technology will understand your mood. Maybe you're in a solemn mood, you're hungry, and that might then make you like a particular type of movie better than some other type of movie. So these systems are going to get more and more sophisticated. Similarly, with Amazon, it is applying similarity analytics, where it's saying you're looking for a bag today. You know, what are all the other bags that I can surface for you? And it's feeding you information within a category. It is then providing you comments that others may have made on similar things they purchased, whether it's the item you're looking at or other similar items. And then it's guiding you to make a decision, which hopefully is to buy on the site that very day. So that's what we've got here are technologies that are far more sophisticated. Doesn't mean that Amazon or Netflix aren't developing more sophisticated things for the future. What I'm saying to you is if you have to read hundreds of thousands of medical journals to make sense of medical words and put them in context and make them available within a matter of a second for a physician to then decide, okay, is this a serious condition or not, and what should I tell the patient? We're operating in a very different realm here. So you're seeing the full spectrum of what's out there, from Siri and Cortana. These are things you can carry around on your phones, to things that you see on the Netflix and Amazon sites, all the way to what you see as technologies we build out in Watson Health.
That was really helpful. We have another question here. Health systems do a lot of big data analytics, but historically it started out with claims and some other types of information that that's what they had available. And as they add more sources of data, it appears that we can do better risk stratification, but it still feels rather blunt. How will cognitive-driven risk stratification change things?
Well, the very important first step is in joining all of the relevant data. So there's a certain amount you can do with just ICD codes in knowing that a person then submitted, went to see the physician, these claims got submitted, these are the conditions that got reported, and that is shallow information on what a person is going through. With being able to read EMR data, which is largely unstructured, where a physician is then reporting an engagement with a patient, you start getting much richer information. Particularly when you get to diseases like a cancer, there's so much in the unstructured data that you can't pick out if you're just scouring payments data, that you're operating in a completely different realm in terms of what you learn about the patient, the quality of analytics you can do, and the relevance of. So we want to assist in the diagnosis and treatment. You can't do that by just saying I looked at all the codes on which you submitted claims in the past. You have to also be able to look at situations, and you know this. A very large fraction, half the country has comorbidities, and often you go for one condition and the codes reflect what the interactions you had and the billing that occurred relative to that condition. When you get to chronic diseases and the elder population, you have to know a lot more about the patient to be doing things that are sufficiently useful. So that's going to be an important shift. Not that the work that we've been doing in the past, the blunt instrument as you described it, is not important. There are many things you can glean from that information. But as we get to answering not only what are the best care pathways, but very importantly, when you start connecting that information with what does it cost for me to either take this medication or have that elective surgery or some other surgery, what's the likelihood of success, how much is it going to cost. That level of transparency has not existed in the industry, and we will have to get there in order for the free market forces to then guide the cost of care to levels where it's reasonable. So I've touched on a few things here related to your question, but happy to say more if you want to probe further.
There's just actually a follow-up question. When you mentioned at the beginning of your answer about the additional sources of data, how will we digest some of the things or incorporate things like social determinants of health, things that maybe aren't directly from a patient or about a patient, but perhaps related to the environment and context in which that patient is living, that person is living? How can we take in that kind of information and incorporate that into much more personalized, if you will, risk stratification?
So there's a few ways this is going to come about. One is in accountable care organizations, they will have a lot more information about you, and then when you start getting, when you're given devices that track your activity, track various other vital signs through the course of a day, and that information starts getting fed into the health systems and combined with the EMR data, you have a much richer data set. In IBM, we're looking at this from a few dimensions. Some of you may know that we bought all the assets of the weather company, so we have weather information on a global basis. I'm using this as an example. So if you're in, let's say, Beijing, we have a good sense of what the risks are for people who have respiratory disease to be out on any given day. And we can predict in advance that maybe there's a week where things are going to be horrible, and if you have asthma or COPD, you should leave town and go on vacation somewhere else and come back, otherwise you're going to wind up in hospital. So that's an example of combining one type of data, which is weather data and environment data, with health information to make a recommendation. What are going to be more common examples are the many types of home medical devices that are going to become available at fairly inexpensive levels. You already have weighing machines that report through wireless and get recorded on your app. And if you're somebody with a heart condition, that is a very good measure of whether you're accumulating fluids or not and whether you should be concerned. So there will be blood pressure cuffs. There'll be all kinds of more sophisticated devices focused on whether or not you're adherent to your medication, your other environmental conditions. There are even companies, as you know, that are trying to come up with very easy, simple ways to test your blood and so on. So all kinds of information will become available, which can be combined with your clinical data, which, as I pointed out, typically happens once every 3 to 6 months for 10 minutes. There will be all kinds of other information that will be brought into the mix to help you with keeping or staying in good health and improving your health.
So, Shiva, how does the cognitive computing platform and methodology take into account data that's garbage versus data that is of higher quality value? How can the cognitive capabilities sift out what's really relevant?
Good. Very early in this presentation, I used this obscure term called hierarchical feature extraction. So there's two answers to your question. One is you need data cleansing technologies that go through and flag data that may seem completely outrageous and either clear the fields or replace them with more sensible information because, for example, you can take A1C measurements, and let's say your readings are 7, 20, 7, 7, 7. You're sort of left wondering, okay, what happened? Was this 20 a mistake or not? And the computer system can check consistency across different dimensions and say, look, this is probably an error. Somewhere it got entered incorrectly, and that seems unusual. Okay, so that's an example of a simple example of data cleansing that a system can do, and there are much more sophisticated technologies in play here. So people who are going to be successful are going to know how to clean data and how to look for missing information, either through interpolation or through flagging that you need to go make measurements that are important. And then the other part of the question is which items are less important and which are more, because this is not a game anymore of saying I'm going to look at 100 variables instead of 5 that I used to look at before. You need to understand which 5 are important in which context, and the computer systems are going to learn and be able to help you with that. So that's what cognitive computing is all about.
Well, that is very helpful. And then next, we're starting to get quite a few questions about some real-world applications of this. How will this help you or me or anyone on this call change their behavior? How will this work to personalize care plans and interventions and even just nudges?
So let me start with changing behavior. An area that, in my view, is still vastly understudied is this continuum between being pessimistic and being depressed. Again, many times people will not take action because they will feel that whatever action they take, things are never going to get better. And this condition afflicts many more of our fellow human beings than we're willing to admit, and is a big cause of why people aren't healthier. People know that if you eat well and exercise well, you're less likely to have problems in life. But that doesn't prevent people from then indulging in bad health behaviors. So what computer systems are going to be able to do is, one, confront you with the facts. Okay, show whether or not you're doing what's needed to be done, and nothing better than if my objective is to take 10,000 steps a day, I have an app, and then I have a fitness device that's telling me, okay, you didn't do it 2 days this week, and those are just the facts. So being able to, one, accumulate the facts. The second is personalization. So there are going to be situations where, well, it's a fairly well-known fact that we are all social in our outlook. Namely, if a friend, a colleague, or a physician, somebody who we think cares about us, tells us to do certain things, we're more likely to do it than otherwise. And so cognitive systems are able to analyze personality, and when combined with the medical tools available to understand the spectrum of pessimism all the way through depression, can then come up with better intervention approaches. It may be that I like to respond to text messages, and all I need is for somebody who I think cares about me to send me a text message every other day to say, great job, you know, you ate well the past few days, or I see that you've been exercising, or I see you've been taking your medications. Fabulous. So positive reinforcement is going to go a long ways, and that reinforcement comes through different channels. Like I said, for some people it may be text, some people it may be email, some people want a phone call. Some people may log on to a social site and see how they're doing relative to a large group that they care to be considered part of. So there are many different ways to understand individual behavior and combine that with the capabilities of a cognitive system to divine the psychological profile of an individual and help them achieve better levels of adherence. I think that's going to be, go ahead.
Yep, that's great. One last question, because we're very close to the top of the hour. I'm trying to combine some themes here that we're getting. People are anxious to know what's already commercially available and what will become commercially available. Particularly, we're getting asked about for physicians, to help physicians start to learn how to use this information and not be threatened by it. I put a lot in one question, I admit, and you only have 2 minutes.
Yeah, so everything I said, some aspect of that is already available today. So the future is here. It's a matter of achieving scale. So some of the technologies that aid in diagnosis and treatment in cancer are commercially available. We've been doing work with Memorial Sloan Kettering, MD Anderson, so on. Some of these products you can go buy. Real-world evidence, we have the data sets. We're now starting to build the next generation platforms. And what you will see happening as a function of time is evolution on a few dimensions. One is the breadth and depth of data that we're tapping into. And so that will keep expanding with time. The second is the sophistication of the analytics. So some of the risk stratification in population health, those tools are available today. The cognitive versions of those tools will start becoming available later this year. The tools that start using personality information, some of those are available, but perhaps not in the medical domain yet, but will very soon, end of this year, early next year, you'll start seeing some of those technologies feeding into the product stream that we have. The third aspect of this, I talked about analytics, the third is engagement. So you'll start seeing different new generations of engagement tools, apps that start being tailored to the individual and start helping improve individual behavior. So lots of exciting stuff happening. I think we will, when we reach out to you with the document, we might even be able to share with you a few websites you can go to learn more about what we're doing. And we look forward to staying connected with you, to working with you, to help improve lives and save lives. So thank you very much.
Thank you very much, Shiva, and thank you to everyone who was on the call today.
As a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 2 business days via email. Also, please take the brief survey when you log off the webinar. We would love your feedback on today's presentation. At this time, the webcast is ended. Thank you for attending and have a wonderful day.